The Elevate kit was created for maxillary sinus lift procedures using magnetodynamic technology. And to this day, it is the tool that offers the simplest, most reproducible, and high-performing approach in the context of crestal sinus lifts. In short, it is a set designed to make surgery predictable, minimizing the unexpected events that are always lurking in this anatomical area. Its use revolves around three fundamental questions. What is it? When can it be used? And how is it used? So that the practitioner can approach sinus lifts with methodical awareness rather than the anxiety of improvisation. The goal is not glamour. It is surgical excellence, meaning clear protocols and consistent results. And since the kit is intuitive, let's start from the beginning. 5 instruments in sequence with increasing diameters, featuring an offset design that allows for comfortable work in the posterior region. At the bottom, a series of laser-etched millimeter mark stops ensures control during insertion and, above all, prevents us from pushing too far during delicate phases such as the placement of the biomaterial. The most common mechanical complication when working on the sinus with a crestal or lateral approach is membrane perforation. The stops are designed precisely to prevent this scenario, providing an insurmountable limit to our advancement. Each instrument has a collar where the stops are placed and an apical portion with different geometries. The first one, Elevate 1, features a more conical tip that allows you to start the preparation without rotary burrs. As the number increases, the tip becomes progressively more cylindrical, matching the target diameter of the implant tunnel. The apical path is concave, collecting the bone removed during tunnel creation and pushing it upward, condensing it along the vertical walls. This way, we take advantage of the typical benefits of magnetodynamic technology. No friction, no heat, and no irrigation that would wash away the blood clot. Moreover, the length of the instrument allows us to work extraorally with better visibility, both during the preparation and at the moment of controlled fracture of the sinus floor. Millimetric control is constant because the stops are always there, visible, clearly marked, so we know exactly where we are and where we shouldn't go. The great thing about the kit is that it includes everything: instruments to create the tunnel and break the floor, as well as tools for delivering the biomaterial. In fact, the osteotomic preparation creates a void that matches the instrument used, since it works axially and not by rotation. This void becomes our personalized plugger. The biomaterial, or a collagen plug, is inserted and pushed in with extreme ease and effectiveness because the plugger has the same diameter as the tunnel. However, deciding when to use it is not a simple choice. Elevate is extraordinary for crestal sinus lifts, but let's remember that not all sinus regenerations can be approached crestellary. In the past, the deciding factor was the amount of residual basal bone. If you had 4 millimeters, crestal approach. Below 4 millimeters, a lateral access was mandatory. The instruments available at the time did not provide enough control for the crestal approach when the residual bone was insufficient. The risk of tearing the membrane and losing containment of the biomaterial was too high. Today, studies including the one by Stuckey, which is often cited and for good reason given its clarity in evaluating the variables that influence regeneration, show that it's not just the amount of basal bone that matters, but also the width of the maxillary sinus. The reason is intuitive. Every regenerative procedure, whether horizontal, vertical, or sinus, related must meet 3 key criteria: primary closure, graft stability, and blood perfusion. In crestal sinus lift procedures, the first 2 are almost automatic. The implant itself acts as a plug, and the sinus is a closed anatomy protected by the upper membrane. The critical part is perfusion. The biomaterial must receive biological signals in order to transform into bone. These signals come from the Schneiderian membrane and, above all, from the remaining bony walls. We're talking about the sinus floor, the lateral wall, which is drilled in traditional lateral sinus, lifts, and the medial wall, which borders the nasal fossae. Unfortunately, the membrane itself provides only a limited contribution to bone transformation. The real vascularization comes from the bone. As a result, crestal techniques are most effective in narrow sinuses, generally under 12 millimeters, and ideally around 10 millimeters measured at the point where the dome begins. In very wide sinuses, lifting the membrane is not enough to bring the biomaterial into contact with the bony walls. The radiographic dome can be misleading, showing something that is not mature bone, but rather unstable fibrous tissue. It can happen then that the implant loses osseointegration at the time of loading knot. because the sinus wasn't lifted, but because contact between the biomaterial and the lateral or medial bone was not ensured. The true secondary stability of the implant comes from the vital bone that bonds with the implant surface. Non-bone tissue contributes very little and won't forgive you if the initial basal support was insufficient. To give you a concrete numerical protocol, you can confidently proceed with the crestal sinus lift using the kit when you have a ridge that can accommodate an implant of 3.8 or 4.3 millimeters while respecting biological thicknesses, and when the residual bone height is at least 3 millimeters. With 3 millimeters, you can reliably manage both the creation of the tunnel and the fracture of the sinus floor. Why do we talk about 3 to 7 millimeters? Because above 7 or 8 millimeters, a sinus lift is often not necessary. You can place an 8.5 millimeter implant without necessarily chasing that extra millimeter. A vertical sinus lift becomes necessary when the 8.5 millimeter implant won't fit. If in the CBCT you find sections with 4 millimeters and others with 3 millimeters, you should use 3 as your key reference point so that all subsequent measurements remain within a safe range. If, on the other hand, you use 4 millimeters and then work in an area that actually has only 3 millimeters, you will unknowingly enter the sinus earlier than intended and disrupt the protocol. So, scan the CBCT, mark the minimum 3 millimeters at the machine's power to 1, use elevate 1 with stop 2, elevate 2 with stop 2, and elevate 3 with stop 2. At that point, you have created a tunnel that puts you in ideal contact with the floor of the sinus. The last two instruments, elevate 4 and elevate 5, are used to break through the floor. Choose one or the other based on the planned implant diameter. For a 3.7 or 3.8 millimeter implant, you finish with the elevate 4, which has a tip of about 3.2 millimeters, resulting in an under preparation of 0.5 to 0.6 millimeters. For a 4.3 millimeter implant, you finish with the elevate 5. A cylindrical tip of about 3.6 millimeters with an under preparation of 0.8 to 0.9 millimeters is perfect for type 3 or 4 bone, which is typical of the posterior maxillary regions. Before the magnetodynamic era, we used drills with clever shapes to wear down the floor without perforating the membrane. Then, using osteotomes or blunt instruments, the membrane was lifted and the biomaterial was inserted. With the classic osteotome technique, you don't remove bone, you break it. The problem was that you still had to start with rotary drills to create the silo. Manual osteotomes weren't enough to excavate the entire tunnel, so bone was removed, you would feel the floor, and only then would you break it. Why not use the instruments from the series with length stops right from the start? Because the first instruments are conical. If you drill with a cone, you end up with a sharp tip that risks tearing the membrane. Ideally, you want to break off a cylindrical core as large as the head of the instrument and push it upward to protect the membrane itself. This approach brings with it a plug of vital bone at the center of the regenerative area, which is an added value in terms of biological information. This is why I consider osteotomic approaches superior to erosive ones. The key advantage of the Elevate kit is that with a single instrument, you can perform both the initial preparation and the breaking of the floor, bringing with you all the benefits of bone preservation plus millimetric control over penetration. With drills, this control was lacking. The preparation was done by feel, sensing the cortical floor through tactile feedback. With the kit, on the other hand, you always know exactly where your tip is, because you work with clear stops, you break through with an instrument larger than a manual osteotome, and above all, you apply the same force, the same angle, the same impulse. The handpiece's energy is constant and doesn't depend on your mood or fatigue. Predictable surgery comes from repeating a protocol that works, not from the operator's spur-of-the-moment talent. That's why procedures performed with Elevate are so similar, same sequence, same power, same measurements. And the clinical cases I show aren't copy and paste, they're proof that standardization produces consistent results. Let's take an edentulous site 1.6 with 3.8 millimeters of residual bone. I prepare and I break through when the stop on the last osteotome, Elevate 5, is set at 4 millimeters. I expect to break through within a range that goes from the initial measurement to the sum of the next two stops, because the floor can break immediately, 3.8 millimeters measured, stop at 4, and do nor, it can deform first and give way later. Sometimes you go past the stop at 4, probe with the ball-ended probe and feel it's still hard, move to 5, still hard. At 6, Finally, it's elastic. You've entered the sinus without tearing the membrane. At that point, you perform the rescue maneuver. Look at the osteotomy, insert the biomaterial with a carrier syringe, and use the same osteotomy, detached from the handpiece, as a manual plugger. You don't need to reach the bottom or detach the membrane with the tip. You want to add repeatable and progressive portions of biomaterial, letting its volume elevate the membrane and make it adhere to the walls. This way, you ensure that the material touches the lateral and medial bone surfaces, that vascularization occurs, and that the remodeling signal is fully transmitted. Radiographically, you will see a homogeneous elevation, a uniform dome that suggests three-dimensional contact with the sinus. This 3D distribution before, during, and after the implant site is what allows the biomaterial to gradually transform into vital bone over time. The primary stability of the implant, supported by the basal bone, evolves into secondary stability thanks to contact regeneration new bone that integrates and the participation of the old bone. If the dome remains isolated, suspended without lateral contact, the transformation fails and the implant loses its anchorage. That's why every step of the protocol has its purpose. Measure the minimum bone, choose the appropriate instrument, set the stops, check with a ball-ended probe, add biomaterial in increments, and never proceed blindly. These are small actions that, when repeated, greatly enhance reproducibility. And no, it's not true that the implant will just help anyway. The implant helps to close, not to turn the granules into bone. That's pure biology, and biology requires contact, blood, and relative immobility. Let's talk for a moment about immobility. The sinus is containing and the upper membrane acts as a natural lid, but if the biomaterial is constantly disturbed, it won't ossify. The same goes for micromobility of the graft. If the material moves during the healing period, fibrous tissue forms. That's why repeated and controlled axial compression with the plugger is essential. You're not just tapping randomly, you're stabilizing. Working without irrigation is an added benefit. You don't disperse the blood clot, which is crucial for the healing cascade, and the extraoral visibility thanks to the length and offset of the instruments reduces fatigue. Less contortion, more control. It's not about glamour, it's smart ergonomics. When you have wide sinuses, don't insist on the crestal approach. That width prevents you from making lateral and medial contact. In these cases, the lateral approach gives you back control of the membrane and allows for extensive wall filling. The rule to remember is simple: narrow sinus, crestal with elevators, wide sinus, lateral approach. The 12 mm threshold isn't a dogma, but it's a useful reference to keep yourself honest. If your dome is floating far away, radiographically beautiful but biologically isolated, you're setting yourself up for a delayed failure. It's better to plan a lateral approach, perhaps combining it with implant placement in a second stage, rather than hoping for the chimera of spontaneous regeneration. Another advantage of the kit is the management of operating times. The sequence is quick, the magnetodynamic energy is efficient, and once you understand the protocol, the learning curve is surprisingly short. But be careful, short doesn't mean superficial. The classic mistake is to underestimate the planning, mismeasure the CBCT, choose the wrong diameters, or play with fire when it comes to the stops. The offset is not just a gimmick, it's truly useful in the posterior sectors where access is difficult. Working actually without rotation gives you a different tactile feedback. You need to get used to it, but then you'll wonder how you managed before. And when you realize that the bone core you push up is a biological gift, you won't want to lose it anymore with aggressive drills. What happens if you perforate the membrane? First of all, it happens less often. The stops help, and the controlled breaking of the core reduces penetration spike. If it does happen, assess the size of the perforation. Small lesions can be managed with a collagen membrane or with internal packing techniques. Large perforations require you to recalibrate your plan, often postponing the graft. However, prevention is still better than damage control. Working with instruments that tell you where you are is the best insurance. Don't fool yourself into thinking the handpiece does everything. You are the one who has to interpret whether the feedback is elastic or hard, use the ball-ended probe, and respect the stop range. Magnetodynamic surgery is precise, but it's not a 3D printer. An often overlooked aspect is communication with the patient. Explaining that you're not drilling, but rather pushing the bone upward with controlled energy reassures them. Factors like less heat, no irrigation, and reduced noise are perceived as advantages. And when you show the postoperative X-ray with the uniform dome, they understand that the design is not random. Clinically, the postoperative period is often calmer compared to lateral approaches, less swelling, less bruising, and faster healing times, as long as you haven't overdone it with the force. I repeat, the impulse is constant, but if you feel that something isn't right, stop and check. You're not trying to set a speed record, you're building bone. During follow-up, verifying osseointegration shouldn't stop at the insertion torque. You need to monitor secondary stability with diagnostic tools, RFA, ISQ, and by assessing the radiographic quality of the newly formed bone. The compact dome that fuses to the walls, the trabecular structure that forms over time, these are signs of transformation. If, on the other hand, the filling appears granular and immobile, the conversion has not occurred. The choice of biomaterial also matters. Osteoconductive, yes, but it's better if it's supported by an autologous portion collected during the tunneling, which adds osteoinductive factors. That's why the concavity of the tip is such a smart detail. It brings you to what you would otherwise throw away. A practical tip: always prepare the carrier syringe and the portions of biomaterial before starting the grafting phase. You don't want to interrupt the flow to look for the right cone just as the membrane has just been lifted. Sequence: create the background, check with the probe, insert the first aliquot, compact with the plugger, check the elasticity again, insert the second, and so on until you reach the desired volume. Then you place the implant. The apex protects the membrane and seals the system. If you have doubts about the amount of material, remember that the goal is not to fill it to the brim, but to achieve contact with the walls. It's better to have broad contact than a central, isolated bulge. The X-ray is your ally, but it's not the absolute truth. Interpret it in light of biology. To sum up, Elevate is a kit designed to make crestal sinus lifts predictable, thanks to a sequence of magnetodynamic instruments with increasing diameters, millimeter stops, a concave tip, and ergonomic offset. It works best when the sinus is narrow and the residual bone height is at least 3 millimeters, allowing for a one-stage implant approach. The key is to follow the protocol. Accurate measurements on CBCT, selection of the implant diameter, calibrated under preparation of 0.5-0.9 millimeters, controlled fracture of the bone core, incremental addition of biomaterial, and continuous verification with a button-ended probe. Radiographic success is an even dome that touches the walls, indicating that vascularization will be able to do its job. And don't forget the obvious. Excellent surgery isn't about strokes of genius, but about repeatable protocols. If you want creativity, paint pictures. If you want bone, follow the procedure. One last note on power selection. Working at power 1 isn't a dogma, but a prudent starting point. Experienced operators can adjust according to bone density, but the rule of tactile feedback always applies. If the cortical bone is thicker and doesn't give way, don't persist with the same setting. Increase the stop gradually, check each step, and keep the rhythm. Remember that the magnetodynamic impulse doesn't remove bone, but moves and compacts it. Your force should be direct, not frantic. Measure twice, strike once. It's the surgery that thanks you, not your ego. Introducing the kit into your workflow doesn't mean you have to throw away what you already know. Integrate, don't replace. If a sinus is too wide, do the lateral approach. If the ridge is as thin as a sheet of paper, regenerate first. Looking for shortcuts is the fastest way to arrive late. But when the situation is perfect for a crestal approach, don't complicate things with unnecessarily invasive techniques. Elevate gives you everything you need, including stops. From an ergonomic standpoint, set up the field with all the measurements at hand. Stops numbered in order, handpiece already connected, sterilize the button probe ready, and biomaterial syringe loaded. Organization, peace of mind during surgery. The patient notices your confidence, fewer pauses, fewer second thoughts, less unnecessary bleeding. Document every step, intraoperative photos, notes on measurements, post-operative radiographs. This will help you grow, teach, defend yourself, and remind you that repeatability isn't monotone, it's controlled quality. When you see that your cases resemble each other in radiographic architecture, it's not because you're copying yourself, but because you found a procedural symmetry that biology appreciates. In medicine, this is called a method. If you're just starting out, practice on synthetic models or in cadaver labs. Get comfortable with the sequence, measure, stop, percussion, check, placement. Don't skip steps just because you think you've got it. Rushing always comes at the expense of the membrane. Always assess the morphology of the sinus. Septa with internal septa can either guide or hinder the dome. Irregular walls require more fractions of biomaterial. Not all sinuses are the same, and not all CBCT scans tell the same story. Read in 3D, imagine in 3D, operate in 3D. If you encounter an unexpected perforation, don't panic. Think about plan B, and plan B must be decided beforehand, not after the membrane starts bleeding. Surgical maturity is shown by knowing when to stop. To truly conclude, Elevate is a simple kit only if you use it with discipline. Simplicity is not triviality, it is the removal of the superfluous. 5 instruments, clear stops, linear protocol. Magnetodynamic technology gives you controlled power. You need to apply judgment, eyes, and brain. Narrow sinus, residual bone, less than or equal to 3 millimeters, properly sized implant, incremental grafting, contact with the walls, graft stability, blood perfusion. This is the mantra. Everything else is just noise. And now go to the clinic, look at your next CBCT with the right perspective and ask yourself, is this a case for Elevate or for a lateral approach? The correct answer is already a surgical act, operational postscript. Every protocol lives and breathes in the small daily variations. You'll come across patients with chronic sinusitis, those with polyposis, or someone who's already had a failed lateral sinus lift and a scarred membrane as thick as sandpaper. With Elevate, you won't work miracles, but you can reduce aggressiveness and maintain constant control. In patients with previous infections, carefully assess the hygiene of the cavity. Consider the use of targeted antibiotics, and if necessary, postpone sinus surgery until the environment is more favorable. Remember that magnetodynamics does not replace clinical judgment. It's a steadier hand, not a sharper mind. If the CBCT shows a septum dividing the cavity in two, first decide whether the dome you create will be sufficient to place the biomaterial in contact with both walls, or if you will need to perform 2 separate lifts. Pay attention to the angulation of the implant. Excessive inclinations can create tunnels that are not coaxial with the instrument, undermining the concept of a customized plugger. Coaxiality is everything. Axial precision ensures that the biomaterial rises like a piston, not like an amorphous mass. And when you have the patient sign the informed consent, make sure to clearly explain what you are doing. Setting the right expectations is half of clinical success and of your peace of mind. Finally, keep track of your results over time. Follow-ups at 6, 12, and 24 months, removal torque if you take out components, SQ values, radiographic density. Share the data with colleagues, compare protocols, and learn from the cases that don't go as planned. The Elevate kit isn't a magic wand, but it's a reliable method when you follow it properly. And like all methods, it can only be refined if you observe it critically. If I had to start over today, I would follow exactly the same path. Study, measure, apply, correct, repeat. Because true innovation isn't the latest gadget on the market. It's the ability to make the ordinary extraordinary consistent. And remember, the patient only sees the result, not the tool. But you know the process that makes it go.